trainees and friends, they watch it on YouTube too. So it's been a great opportunity. So thanks again, Eric. We'll jump right into it for today. Here are the three big things that we're going to talk through. The first thing is just getting a general sense of the anatomy of the stomach, and then the two big indications that are consistently used and have been explored plenty in the literature. We will talk through those two. The first one is evaluation of NPO status or gastric volume status, and then confirmation of tube placement. So gastric volume assessment, I think these are some areas, some rationale where I think I find this to be useful. So when the NPO status is unclear, either because a patient just came to the ICU from somewhere and there isn't a family member and you didn't get a report on what their NPO status is, or if you have an urgent need to intervene on the airway and you want to make sure that the patient is NPO, but because of the urgent nature, you don't have either opportunity or person there to obtain history. In any patient with delayed gastric emptying, when it's unclear whether or not it would be safe to intervene on airway before making sure their NPO status. And then if there's history of unreliable or poor history, that might be another rationale to do this as well. There's pretty rich evidence in literature. There are over 70 pediatric studies, I think, outside of lungs and heart. I think this is probably the most well-studied area in point-of-care ultrasound. Out of those 70 pediatric studies, 47 studies looked for gastric volume and emptying. It has been done by a bunch of different clinicians, from neonatologists to the surgeons. It's generally pretty easy to learn this and provides a good degree of accuracy. So I think there's rich evidence to support this in practice. Probe choices are pretty reasonable. I think for most young children, a linear probe is great, but then a curvilinear probe with a shallow depth may actually also be quite helpful because of just how wide the footprint is, and it offers you a lot more opportunity to see the adjoining structures and understand where exactly you are. In terms of anatomy, stomach is great. It's sort of this kind of free-floating structure, which is suspended by all these ligaments to the neighboring structures. So you have the gastrohepatic ligament that's connecting your stomach to the liver. Then you have the gastrosplenic, gastrophrenic ligaments, and greater omentum. So these adjoining structures provide you such a great window to exactly know where you are and image the stomach. The things we're going to focus on is your different parts of the stomach. You have your fundus, your lesser and great curvatures, your body, and then the pyloric sphincter and the pyloric canal. The distinct feature about the stomach are these like rugae and multi-structure wall that makes it easier to find and differentiate from duodenum and jejunum and other parts of the intestine. So those are some very helpful cues to understanding this. Different parts of the stomach, the probe placement is different. So the most important one is the view of the antrum. And it also often ends up being the most simple view to get consistently. Generally, the probe is placed just below the xiphoid process in a sagittal plane. Sometimes you have to be a little bit paramedian, more towards the spleen than the liver. But generally, that's a good window for the body of the stomach. This is placed more in an oblique plane. And as you can see, it's just right below that left subcostal margin. When the stomach is full, and especially when it's mixed with air, it makes it a little bit difficult to see the body. But that's a good window, and it's used to see that part. And then finally, fundus, you try to approach it in this left mid-axillary to anterior axillary line and use the spleen as your guide and be more anterior to try and find the fundus of the stomach. A lot of times when some of our trainees are looking at spleen and that left lung, they'll often find the stomach accidentally and misinterpret it for a fluid collection within either the chest or the abdomen. So just something to consider there. In terms of the gastric antrum, so as soon as you place the probe, generally what you want to use as your anatomical landmark is this lobe of the liver or the tip of the liver. And so the gastric antrum in that sense is just posterior to that tip of the liver. And then sometimes you can see the pancreas. At other times, you can see either aorta or your SMA come into the view, though these are not always present exactly in every patient. They're not exactly the same. Sometimes you can see SMA, sometimes you can see aorta, sometimes IVC also comes in and out of the view in this one. Generally, when the stomach is completely empty, you can see it completely collapsed and the anterior and the posterior walls are quite distinct. So that's helpful to make the distinction. It is the easiest to see the stomach when the patient is actually NPO and has almost no distending volume. This is what the gastric antrum looks like right after a liquid meal. My personal experience is generally that whenever there is a liquid or a solid meal, it's very easy still to see the anterior border of the stomach, but the posterior border of the stomach is rather hard to see and define clearly. What does help is if the patient is in right lateral decubitus position. So that would be a helpful maneuver to try if you're not able to see the anterior and posterior wall, or when you're trying to actually measure the volume quantitatively, that maneuver is more helpful than having the patient on their back. These are another set of pictures from, I want to say, ASA website. So this is the stomach antrum. As we can see, it looks completely collapsed in a patient after 8 hours of fasting. It looks well distended. You can still see the anterior and posterior walls after a 500 cc liquid meal. And like we said earlier, in this case, you don't see the aorta, you can see the IVC and the mesenteric vessels here. These are some more pictures. The one on the left is with effervescent water or soda, and you can only see the anterior wall. The rest of it is this dirty shadow that we see all the time from stomach, even when we're doing the subxiphoid view of the heart. And then with a left lateral view, that makes it a little bit more helpful to see. So this is what we were talking about. Here's another picture of the gastric antrum, this time with a solid meal, and it looks a little bit more well-formed and identifiable here. Another picture where the patient's gastric antrum is distended from a solid meal. Then for the next part we want to talk through is the gastric body. And then just to remind everybody, this is a little bit less of a sagittal plane. This is more of an oblique plane. And oftentimes what you're doing is you're using the liver and the edge of the liver as a guide to understanding where you are in the stomach. And often it requires more probe adjustment than the views for the antrum. You may have to do some rotational corrections too with the oblique view to get it in plane. And the best way to recognize it is, again, when the patient is fasting and you can see the anterior and the posterior walls with like the several different layers of the stomach. So with those view, we're going to talk about how to actually do the gastric volume assessment. And so what is recommended in the literature is to get your gastric antrum view in right lateral decubitus position. and then either to measure the anterior and posterior, uh, uh, length and the width of the stomach in that, or you can also use the automatic uh, cross-sectional area tool if it exists in your machine. Neither one is more accurate than the other, but they are both helpful. And then based on doing these measurements, the study that's mentioned here, they use a regression analysis to come up with this calculation. The authors, they did an excellent job of helping put together what does it mean in terms of the total volume in the stomach with regards to risk of anesthetic administration and airway intervention. And so the way they approach this is they do a qualitative exam. If the stomach is empty, then it's grade 0 and low risk, and that patient can definitely go for anesthesia. If they see a solid meal in the stomach, the patient is high risk, and that is a patient that, unless something is emergent, they would tend not to do it at that time and defer for later. When they see clear or effervescent fluid in the stomach, they do gastric volume measurement using the equation we talked about. And then the volume is broken down into grade 1 and 2. Grade 1 is usually suggests more or less empty stomach with some gastric secretions and is safe to proceed with anesthesia, versus if it's grade 2 with these volumes, then either delay or proceed with caution. So I found this super helpful in decision making. They also did an excellent job of providing what is the estimated volume based on different cross-sectional areas using that same regression equation. So if you're lazy like me, you could just use the table and not have to even do your own calculation. So that's all I have for gastric volume measurement, generally pretty straightforward technique. Next one is NG tube placement. Why to do it? I think for the most part, X-ray is a good alternative for it. So it's not a routine part of my practice to use ultrasound for NG tube placement. It is a quick and rapid way of confirming. There are a few studies which have demonstrated its efficacy. And we know that a misplaced nasogastric tube can cause a few different complications. And so confirming it with a safe and easy test is obviously helpful. The protocols that we're going to discuss come from two different studies. This first one was published in 2021 in Chest, very robust methodology. This was a multi-centered study, if I remember correctly, included 8 centers. Everybody did about 10 hours of training on the same content, and then there were total 526 nasogastric tubes placed. Even with such a robust training process and methodology, at least 7 to 8% of the times, they could not figure out where the tube was. But in the rest of the sample, where they could figure out, the sensitivity was, and sensitivity and specificity were both quite high, with great positive predictive and negative predictive value. Just to reinforce, it did not include the 7.6% patient. It excluded that and then did the calculations. What was their protocol? The first thing they did was they looked at stomach in the 3 different views that we talked about previously, and looked for if they could see a single or a double hyperechoic line. If they could, they deemed that to be the correct NG tube location. If they did not, they used what's described as the dynamic fogging. So they injected about 40 mLs of air, which is not a huge volume since all the patients in the study were adult patients. And with this dynamic fogging, if they could see that in the stomach, then it indicated correct NG tube position. But if they did not see that, that was misplaced, and then they had to replace the tube. So these are the views. Instead of using the sagittal plane, they used a more transverse plane. And so that's how they could see the gastric antrum in that more finger-like projection. and they've shown pictures as empty and full. And then there's that mid-sagittal view, which we've already talked about. Gastric fundus view we talked about, and this is what dynamic air fogging looks like. So I thought that was pretty straightforward way of doing it, but it is an indirect way of confirmation, and so you don't actually really know where the tube is. It's based more on an assumption, but it worked well for the study. There's a pretty helpful editorial that is written on that. And I think like as much as the paper is helpful when you read it, I think reading it together with the editorial makes a big difference. So I would definitely recommend people to look this part up with the study. The second one was based more on the direct visualization. This included 114 critically ill patients, and they used what's known as the 4-point method. And this included visualization of esophagus. This is the same view that you use for confirmation of endotracheal tube. So instead of looking for airway and endotracheal tube placement, here you're getting the same view, but you're looking at esophagus and distension of esophagus when you place a big enough feeding tube. And then you're looking in the epigastric area to confirm passage through this esophagogastric junction, then positioning in the fundus, in the antrum, and finally sonography of the fundus. And they finally used an X-ray to confirm tube placement. In their study, in these 114 patients, they were able to confirm this in 100% of the patients. It took them about 10 minutes to perform the ultrasound and a total of 40 hours of training. In my limited experience, I found this protocol to be a lot more challenging to implement and certainly not 100% confirmation rate, especially if there is gastric content present. If your stomach is empty, it's much easier. But with either liquid or solid meal, it's just so much harder to do. These were some of the pictures from their paper. This is where they get that paramedian view of the airway. Look at the esophagus. The esophagus, normally triangular in shape, is distended open by an NG tube. And then they move on to their mid-epigastric view and look for the tube in the gastroesophageal junction, followed by tube in the gastric antrum, and then finally they inject a little bit of saline or fluid and try to find it in the fundus. So overall, a little bit harder to do. This is a meta-analysis that was done back in 2022. It included 14 studies, about 1,800 patients, really high accuracy of the test, great sensitivity and specificity, very little spread around this AUROC. So that tells me that not only is the data good, but it is also consistent across all of the different studies that have looked into this question. So with that, I think like there is literature supporting its use, but it's not very common, at least in our ICU, to use this as a consistent modality right now. So that's all I have for today. It's a much shorter topic than some of the other ones. I'm happy to take any questions.